Okay. So good evening. I'm Dr. Abhijit Trailokya, heading the medical department of Alchem Laboratories. Welcome you for this DAPANORM conclave. So today's topic of discussion is time to take the lead, practical utilization of SGLT2 inhibitors. And for today's discussion, we have international faculty with us, Professor Pradeep June. He's from University of Glasgow, UK. And from India, we have Dr. Rajiv Agrawala. He's going to moderate the entire and along with Dr. Rajiv Agrawala, we have Dr. Kalpana Das with us, and then Dr. Rajan. He's from Durgapur, India. So with this, let me take you through agenda. So we'll start with the opening remarks and introduction of panelists. Then Professor Pradeep June talk about time to take a lead, practical utilization of SGLT2 inhibitors. Followed by Dr. Rajiv Agrawala will throw light on heart failure therapies journey across all ejection fraction. Then we'll do a panel discussion on various topics, and again will be moderated by Dr. Rajiv Agrawala, with Dr. Rajan, and then Dr. Kalpana Das, and of course definitely with Dr. Pradeep June. We will take few questions from audience, if the time permits, and then we will close with vote of thanks. So this is what the agenda about the today's program. So let me take an opportunity to Dr. Pradeep June, the Professor Cardiology and Epidemiology in Cardiovascular and Medical Sciences, University of Glasgow, UK. Professor June is a fellow of European Society of Cardiology, Royal College of Physicians, Edinburgh. Has been involved in number of multinational randomized clinical trials and investigator as an investigator and the member of clinical endpoint committees. Co-authored more than 200 publications in various journals like NEGM, JAMA, and European Heart Journal. Also co-authored 2 chapters in ESC textbook of cardiovascular medicine. Associate statistical editor for circulation, heart failure, and then the most important thing is his work on DAPA-HF, DELIVER, Paradigm HF, and then Paragon HF trials. So with this, thanks Dr. Pradeep June for joining our program. Along with sir, we have the consultant Merit, is the chair of Department of Cardiology at Jaswant Rai Specialty Hospital, Merit. He was awarded Amar Ujala National Excellence Award for Lifetime Achievement, and then various other awards like Lifetime Achievement Award in 2017. Inspiring Doctor of India Cardiology in 2018 by Economic Times. Health Icon by Times of India and Charan Laboratories Private Limited. Literacy Excellence Award in 2018 by Bharat Nirman. So welcome Dr. Rajiv Agrawala for today's program. We have Dr. Kalpana Das with us. She's a consultant endocrinologist from Raipur. More than 34 years of experience and practice at Apollo Sugar Clinic, Raipur. She's a member of American Endocrine Society and Ayush Medical University. Also member of RSSD, ADA, and IMA. So welcome, madam, for this program. And we have Dr. Rajan with us. He's a consultant endocrinologist, Mission Hospital, Durgapur. 15 plus publications in Index Journal and 150 plus citations. Reviewer of international journals, 4 chapters, 4 book chapters, and a member of Endocrine Society US and an Endocrine Society of India. So welcome Dr. Rajan for this program. So with this, now I would like to hand over the session to sir. Over to you, sir. Pradeep.
Thank you very much for that kind invitation. I'm just going to share my screen. It's a pleasure to be with you here this evening and to talk about dapagliflozin with this distinguished faculty. So I'm just going to talk for 20 minutes about my views on how to take the lead in practically using SGLT2 inhibitors in patients with particularly heart failures. That's my special area of interest. These are my disclosures. So why use an SGLT2 inhibitor? Well, I think you probably know this already, but for heart failure, we need something more this is the Paradigm HF trial, which was a trial that showed sacubitril valsartan, or as it was called at the time, LCZ696, was better than enalapril. But what you can still see that even in the group who received sacubitril valsartan or LCZ696, there's still a residual risk of cardiovascular death or heart failure hospitalization. And we know that our patients with heart failure have recurrent heart failure hospitalization and are likely to die earlier. So why did we need something more? Well, this is why we needed something more, because our patients, despite being on an ARNI, sacubitril valsartan, a beta blocker, and an MRA, they still have residual risk. Now, what can we use to reduce that residual risk? Well, we were very lucky that our colleagues in diabetes had discovered these drugs called SGLT2 inhibitors that showed a reduction in the risk of heart failure hospitalization in these various trials of the SGLT2 inhibitors in patients with type 2 diabetes. These were big trials showing massive benefits in terms of morbidity and mortality. So given the big reductions in heart failure hospitalizations, we thought maybe they'll work in patients with heart failure. And as you're all very much aware, we presented the results of DAPA-HF at the European Society of Cardiology back in 2019, seems a very long time ago, showing that dapagliflozin reduced the risk of cardiovascular death and heart failure events, that's heart failure hospitalizations and urgent visits for heart failure, by 26%. So on top of standard therapy for care, we could further reduce the risk of our patients with heart failure with reduced ejection fraction. So these patients all had an ejection fraction of 40% or lower. And that trial was followed soon by another trial using empagliflozin, showing a very similar relative risk reduction. So the SGLT2 inhibitors work in heart failure with reduced ejection fraction in patients with and without type 2 diabetes, which I'll come back to later. And that it was very clear that these drugs were beneficial. So in the recent guidelines for heart failure, SGLT2 inhibitors are front and center of what we do. They are the basis for treatment for heart failure to reduce mortality for all patients. So now we have ACE inhibitor, ARNI, depending on what you want to use. You have beta blocker, MRA, and SGLT2 inhibitor, all being the drugs of choice for treating heart failure with reduced ejection fraction, all with 1A recommendations in patients with heart failure. Okay, so these are the drugs to use. So that settles the question of should we use them? Why should we use them? We should use them because they're effective, they're in guidelines, but it's difficult sometimes. Patients are different, no patient's the same. There's lots of grey areas. Patients don't fit nicely into guidelines. So we have to use clinical judgment about things like when to initiate SGLT2 inhibitors and how to use them safely. And now I'm going to move on to about the practical uses of an SGLT2 inhibitor. So another thing to think about is when to start them. These trials were in outpatients, but actually I think you can use them in inpatients very easily. Patients are decompensated. And in fact, in the new guidelines, the new European Society of Cardiology guidelines, in the part where it looks at the management of patients with decompensation after relief congestion, it suggests that you should optimize medical therapy with a class 1C recommendation to get oral evidence-based therapies administered before discharge. So in the patient in hospital, I think you can administer these drugs. And I think you need to do that because the benefit of these drugs is seen very quickly. So the patients who were in DAPA-HF, when we randomized them on day 0, by day 28, there was already a statistically significant reduction in cardiovascular death, heart failure hospitalization, and urgent visits compared to the patients who received placebo. There was already a benefit apparent. So the benefit is very, very quick in these drugs. And indeed, it might be even that you use that to your benefit. Here's an analysis that we performed, and it was published just a few months ago in the European Heart Journal, looking at using drugs in the different order from the traditional order of ACE inhibitor, beta blocker, MRA, then SGLT2 inhibitor in sequence, which is sequence number 1. You can see that takes a long time to do. And here's the event rate that you would get at 1 year if you went through that titration sequence. But if you actually maybe did a more rapid initiation, started with SGLT2 inhibitors, which of course you can start at 10 milligrams once daily and you don't have to dose titrate, then add an MRA with very little dose titration, and then work on the drugs that require dose titration, actually, because of that very quick benefit of SGLT2 inhibitors, you can reduce that event probability from 128 to 81 at 1 year per 1,000 patients. So you get a reduction of 47 events per 1,000 patients over 1 year, if instead of going from a sequential up titration of drugs, you start with these drugs and start quickly up titrating them. So I think we have to revisit how we use these drugs, and I think we can do better with using these drugs in patients with heart failure. It's definitely possible to do better by using these drugs. But how do you do that safely? Well, of course, as clinicians, you want to make sure that you use the drugs safely, not only the drugs that are effective, but using them without causing problems. So I'm going to spend a bit of time going over the adverse events in DAPA-HF, because I think people are still a little bit worried about the safety of these drugs. In DAPA-HF, we only collected information on serious adverse events and adverse events of interest. The reason for that is that we had many tens of thousands of patients in the type 2 diabetes trials who had been exposed to dapagliflozin that we knew about in terms of things like UTIs, mycotic genital infections. Now, we know that those are a side effect of SGLT2 inhibitors, but they're a manageable side effect by making sure that your patients practice good genital hygiene, wash daily, keep themselves clean. You can really reduce the risk of these mycotic genital infections. And if the patient gets them, they can be easily treated with antifungal creams. Obviously, if the patient has recurrent events, then that's something you may need to consider. But most of the time, these are one-off events that can be easily treated and the patient can continue in therapy. So, adverse events of interest, what did we see in heart failure patients? Because we worry about things like volume depletion, renal adverse events, because our patients always struggle with renal problems. But actually, these events were no different in the patients randomized to dapagliflozin compared to placebo, and in fact, less renal adverse events compared to placebo in the patients receiving an SGLT2 inhibitor. And I'll come back to renal events a bit later. Fractures and amputations at one time were a worry with SGLT2 inhibitors. I think that worry has gone. There's no difference between placebo. And of course, hypos are an issue if you worry about patients with diabetes and ketoacidosis. But these are actually very, very rare complications of SGLT2 inhibitors when you use them on a large scale. And in fact, the likelihood of having these complications is actually lower than the likelihood of having angioedema due to an ACE inhibitor. So they're actually quite rare complications of SGLT2 inhibitors. And I don't think they should prevent you from thinking about using these drugs. And finally, any AEs leading to discontinuation, no difference between the two groups. In fact, very few patients discontinued the drug, only 5% there. And you can see similar rates in the placebo group. We didn't see very much dose down titration with DAPA in DAPA-HF. You remember the drug is given at a 10 milligram once daily dose. You can reduce to a 5 milligram once daily dose, but actually we found in clinical practice and in the clinical trials that that's a very, very rare occurrence, and you should always try and prescribe 10 milligrams once daily, and then you don't have to do any more titration of the drug. We also looked at those adverse events according to diabetes, and you can see here, I just want to highlight here that the hypoglycemia and ketoacidosis all occurred in patients who had a previous history of diabetes. So in patients without diabetes, you're not going to get hypoglycemia, you're not going to have to worry about diabetic ketoacidosis. It's only in those patients with diabetes, and in those patients, these are rare occurrences. I've mentioned UTIs, urosepsis. Again, there was no difference in the two treatment groups. And genital infections, again, were very rare, very small numbers of these events. But again, as I've said, these can be easily managed. What about Fournier's gangrene? Fournier's gangrene was always was one of the things that we were worried about. Actually, we had only one report of that, and that was in the placebo group. So that was not an issue that I think we worry about with the SGLT2 inhibitors these days. All of these events, as I've said, hypoglycemia, ketoacidosis, all in the diabetes group. Now, patients with heart failure, one of the things that we have to worry about with them is blood pressure. We know that in patients with heart failure with reduced ejection fraction, many of them have low blood pressure. Some of us worried that dapagliflozin might reduce blood pressure in these patients. But actually what we saw was this very minimal effect in blood pressure. In 4,744 patients, there was a 2 millimeter change in blood pressure overall. Now, 2 millimeters of mercury change is almost undetectable clinically. That's well within the variation of measurement you get from minute to minute in a patient. And indeed, if you look at the patients who had a low blood pressure at the start, their variation in change in blood pressure was even lower, of the order of about 1 millimeter mercury. So these drugs do not lower blood pressure unless your blood pressure is high, in which case you get a 3 or 4 millimeter mercury drop, but that blood pressure change comes back anyway. So these are not drugs that we need to worry about lowering blood pressure with. What about renal function? That's the other thing we struggle with heart failure. Now, I said I would come back to renal events. I showed you that renal adverse events were actually less common in patients with heart and dapagliflozin. And in fact, if we look at the renal events, a 50% sustained decline in eGFR, reaching end-stage renal disease, so requiring dialysis or a renal transplant or renal deaths. Numerically, these were less in the DAPA group compared to the placebo group, but it didn't reach statistical significance. There weren't very many events, 28 in the DAPA group, 39 in the placebo group. But you can see a hint towards benefit here. And again, I'll come back to the renal effects of SGLT2 inhibitors a bit later on in terms of outcomes. But what we did see is that what DAPA does is it slows the rate of decline in eGFR that occurs in patients with heart failure. So the normal decline per year in a patient without any comorbidities is 1 mil per minute per 1.73 meters squared. And in a heart failure population, that's nearer 3 mils per minute per year. What DAPA did was it reduced this decline back to the normal age-related decline in eGFR. So over time, it actually preserves renal function if you stretch out these curves over time. These curves cross over and you get a benefit in terms of preserving renal function. Now, the astute of you will know about this dip, this initial dip that you get in eGFR when you start an SGLT2 inhibitor. That is normal, nothing to be afraid of. It is small and suggests that the SGLT2 inhibitor is working. Now, what's the impact of that? Well, actually, if you see that in your patients, I don't think you should stop the drug. It's actually a sign the patient is getting benefit from the drug. Here's the impact of that initial dip on the outcome of cardiovascular death or heart failure hospitalizations or urgent heart failure events after day 14, according to the eGFR dip. So let me take you through this. At day 14, after starting dapagliflozin, if your eGFR dipped down and was lower than it was at day 0, then actually you were at lower risk of events than if your eGFR stayed the same or went up. In the placebo group, if your eGFR went down after starting placebo, you're at higher risk. So your eGFR going down on dapagliflozin is actually a good thing. It shows the drug's working and it puts you into the group who are less likely to have events after the dip. So not a reason to stop the drug. What about using the drug to reduce the burden of diabetes? I know we have some distinguished faculty here who are endocrinologists, and I hope this might be of interest to you as endocrinologists who are listening. We know that there was no difference in the primary composite endpoint in DAPA according to whether the patients had diabetes at baseline. The effect was the same. But what about other glucose-lowering medications? Okay, we know that DAPANORM comes also bundled with metformin. What about the patients who are already taking other glucose-lowering medications? Well, actually, it didn't matter if you were taking glucose-lowering medications or not. The benefit was the same in these two drugs, in these two groups. And in fact, in the patients who did not have diabetes at baseline, the drug reduced the risk, dapagliflozin reduced the risk of new onset diabetes. So by giving a patient with heart failure with reduced ejection fraction who doesn't have diabetes, heart failure with reduced ejection fraction, you can reduce cardiovascular morbidity and mortality, you can reduce renal decline, and in the patients without diabetes, you can reduce the risk of developing diabetes. So lots of benefits, lots of different patients to receive dapagliflozin if they have heart failure. And as I've said before, it didn't matter what glucose lowering therapy you were on, whether or not you had diabetes, the treatment effect was the same. Whether you're on glucose lowering therapy, yes or no, whether you're on metformin, a sulfonylurea, insulin, DPP4, lots of different glucose lowering therapies, different combinations. The benefit of dapagliflozin was consistent when adding it to these therapies. Now, I said I would turn to chronic kidney disease because as heart failure doctors and as endocrinologists, we all struggle with renal dysfunction. So what about patients with renal dysfunction? Are these drugs benefit in these patients? Well, we had DAPA-CKD, which looked at dapagliflozin in patients with chronic kidney disease, looking at patients with an eGFR of 25 to 75, with a UACR of 200 to 5,000, already on an ACE inhibitor or ARB, randomized to DAPA, again, 10 milligrams once daily, that's the dose you want to use, or placebo, and looked for the outcome of a sustained eGFR decline, end-stage kidney disease, renal or cardiovascular death, and there was a clear relative risk reduction there. Sorry, it's come off the slide, but clearly you can see patients in DAPA did better. So in the last 2 minutes, I want to just say a few things about what's coming up now for dapagliflozin in the cardiovascular space. So I've shown you the results of DAPA. You know, Emperor Reduced also showed a benefit of empagliflozin in patients with heart failure with reduced ejection fraction. And we've had Emperor Preserve, which was empagliflozin in patients with an EF of over 40%. Soloist Worsening Heart Failure looked only at patients with type 2 diabetes and decompensated heart failure. And we've got a few other trials that are going to look at decompensated heart failure as well, but in the reduced ejection fraction. But what we have soon is DELIVER. Okay, Emperor, this will help us answer this question. So in Emperor Preserve, we saw a reduction in the primary composite endpoint of cardiovascular death or heart failure hospitalization with empagliflozin, a relative risk reduction of 21%. But this was mainly driven by reduction in heart failure hospitalizations rather than cardiovascular death. And what we're going to do in DELIVER is show you the same results, but using dapagliflozin. And we know from a press release on the 5th of May that dapagliflozin met the primary endpoint in DELIVER, which was our phase 3 trial at reducing our primary endpoint of cardiovascular death or worsening heart failure in patients with preserved ejection fraction. Now, the background and baseline characteristics of the DELIVER trial have already been published, and we're going to be presenting the results at the ESC Congress. And here's a session that we'll be presenting it in on the 27th of August at 3:30 Central European Time. You can come to Barcelona to see the results, or you can register online and watch online. Scott Solomon, who is the PI of DELIVER, is going to present the results of DELIVER, so we will know the precise data on the benefit of dapagliflozin in HFpEF. And I will be presenting a pooled analysis of DAPA and DELIVER, looking at the benefit of dapagliflozin across the entire ejection fraction spectrum. So all patients with heart failure, regardless of their EF. So I hope some of you will be able to join us there in person or online. So in summary, every patient, I think, with heart failure deserves the best therapy. I think all patients with type 2 diabetes certainly deserve to have an SGLT2 inhibitor. It's beyond question it's beneficial in those patients. It's certainly beneficial in heart failure with reduced ejection fraction and patients with chronic kidney disease following DAPA-CKD. I think it's possible to safely initiate an SGLT2 inhibitor in the broad population with heart failure, and prior to discharge is recommended to guidelines and can be done safely. I think if you do that, the faster initiation of therapies reduces morbidity and mortality faster, you get more benefit, and I hope that come August, when we release the results of DELIVER, that indication for SGLT2 inhibitors will broaden out to include HFpEF. So on that note, I'd like to thank you very much. I'm looking forward to the other presentations and to taking questions a bit later on. Thank you.
So thank you, Dr. Pradeep. It was really, excellent presentation on the SGLT2 inhibitor, when to start, what are the precautions one should take. And then definitely we are all waiting for the result of dapagliflozin in preserved ejection fraction. So with this, now I request Dr. Dr. Rajiv.
Yes.
Okay, sir.
Thank you, Dr. Abhijit, and my special thanks to Dr. Pradeep for giving us a helicopter view of SGLT2 inhibitor in the spectrum of heart failure. And its special relevance in diabetes and chronic kidney disease, and almost all phenotypes are being benefited. So my job in next 10 to 15 minutes is to take you through the journey of heart failure therapies, especially in relation to SGLT2 inhibitors across the EF. And this is my favorite slide, which I keep showing every time I speak on SGLT2 inhibitors, which is very historical, ancient, and very practical slide that both the therapies, they work, SGLT2 inhibitors work when they are heart and kidney are in conjunction. So that knowledge was probably not known in words, but conceptually the kidneys and heart were put back to the mummies in ancient Egyptian times. If we look at the spectrum of heart failure, this is a classical description which is more widely accepted. Heart failure with reduced ejection fraction, symptoms and sign with EF less than 40%, mid-range and HFpEF. All of us are aware this kind of classification, which is very much arbitrary. But what is important to understand is that every syndrome has to have signs and symptoms of heart failure. Say, do not qualify for heart failure. So you have to have signs and symptoms of heart failure, and then you can subclassify this patient population. So this is a very spirited article and my most favorite article. And I talk on this aspect, that how we place SGLT2 or other therapies in the journey across ejection fraction. If you look, ARNIs, aldosterone, beta blocker, and ARBs, what is very common and interesting to note is that mid-range ejection fraction, which is pink reflection on this slide, up to this point, the therapies are very, very effective. And as the ejection fraction crosses beyond 50, the incremental benefit stops. In fact, the curve is going up. So there is a harm element also. And this is unanimous, whether you use ARNIs, whether you use aldosterone inhibitor, beta blockers, or you use ARBs. So why it happens so? If you look at the conceptual etiopathological model, that how it happens, on the left side is the reduced ejection fraction, where there is an excessive neurohumoral drive of the body On the right side, which is red colored, you find that the neurohumoral drive is less. And in fact, this disease syndrome is not homogeneous, as you have HFrEF, where comorbidities, they predominate and the outcomes of these therapies are not beneficial, meaning thereby the comorbidities restrict the yield of neurohumoral blockade, like obesity, like obstructive sleep apnea syndrome, simple aging. So these therapies are being blunted by the comorbidities. So this is a conceptual model that on the left side, neurohumoral activation is tremendous, and these therapies, they work well on the left side, but on the right side, so-called HFpEF, their effects are blunted and comorbidity dictates the outcome. When you come across this kind of understanding, I think the best definition of normalcy is being given by British Society of Echocardiography, which define up to 50 is impaired ejection fraction. They do not talk of mildly reduced as talked in European as well as in ACC AHA guideline. In my personal opinion, I like the definition of British Society of Echocardiography, because if you create a class like heart failure with mid-range ejection fraction, its behavior is more like HFrEF patient. So it's a good idea, a simplistic idea, that we club this patient population. So the yield of outcome will be relatively lesser with these therapies. So to my mind, we need a very simplistic partition, which is once again arbitrary. And to my mind, that cutoff is 50%. EF per se is a very, very contentious issue when we talk of heart failure. But whatever you may say, EF continues to be the best denominator in understanding and application of these therapies. This is as contentious as LDL versus non-HDL or ApoB, how you define it, but the therapeutic options are based on LDL. So my take on EF is the simplistic view: less than 50, more than 50. If you're less than 50, you're more like HFrEF. I'm just trying to simplify the journey across. The SGLT2 inhibitor, they continue to show benefit all along the pathway, while if you look at the ARNI, Paragon, the effects are lost if the EF moves more than 55 or so, and in males. So there are two riders in Paragon, EF more than 55, and male population, they are not being benefited, while this gender neutrality of flozins continues to be all along the ejection fraction. That is what being magnified on Paragon, that the EF, once it crosses 55, the yield becomes negative. So there is a basic difference that the yield of SGLT2 inhibitor, although blunted, but continues to be across the ejection fraction and unrelated to gender. And not only this, the red one is SGLT2 inhibitors and the blue one is the ARNIs. Whichever parameter you take, cardiovascular death, heart failure, hospitalization, time to first hospitalization, CV death, total first and recurrent heart failure hospitalization, the red, they do better. That means if we take head-on comparison between the SGLT2 and ARNI, the SGLT2 do better all across the spectrum. Of course, it is a postulation. There is no head-on trial. So that is another message which I want to give you. Talking very simple, and of course, all of us know there is no one mechanism, but there are mechanisms beyond HbA1c, BP weight, and EGFR, which are the direct effects of sodium hydrogen exchanger, adipokines, ectopic adipose tissue, and fibrosis. And you can imagine these effects the bottom, these effects, last three effects are very, very important in HFpEF patient population. Same way, we look the improvement in diastolic dysfunction, atrial remodeling, decreased fibrosis, decreased hypertrophy, decreased arterial stiffness, decreased load, decreased interstitial volume. These all things are very, very important in management and etiopathogenesis of HFpEF syndrome. So these are simple mechanistic pathways and very difficult to quantify. So just again to memorize you and hit the bullet point is, if we place all these patients across dilated cardiomyopathy, the British Society of Echocardiography description, all these therapies are purposeful and they have incremental benefit on one another or one top of one another. But once the EF moves away on a higher side, SGLT2 inhibitors are the best therapies which can be used in every situation. But look at the spironolactone, which is also possibly beneficial, loses its effect on higher EF. It is complicated by interaction of chronic kidney disease and low BNP, because that is a very big problem in HFpEF patient where obesity, adipose tissue metabolizes BNP, and artifactually the BNP, despite being high, is seen as low because of excessive metabolism. So we have declining definitive evidence of improvement at higher EF. I think that summarizes the whole game plan, that how you can place different therapies across the EF. And the simplistic is that SGLT2 inhibitor, they are the best winners and continue to show benefit all across the ejection fraction. I'm stuck. So just talking the spirit of guidelines, which is being reflected in HFrEF, you see the blue vertical bar, which shows that SGLT2 inhibitors can be used in any and every situation, and the inspiration is drawn from DAPA-HF and AMPRA reduced. But if you look the syndrome of HFpEF and HF mid-range, SGLT2 is the only therapy which is given class 2A indication in both these situations, while rest of the therapies are class 2B. Once again, emphasizing that probably the best therapy at the moment across the whole spectrum of EF is SGLT2 inhibitors. At mid-range up to EF of 40%, it is probably class 1. Mid-range, it is class 2A, and HFpEF, again, it is class 2A. What Dr. Pradeep has shown is my very favorite article in recent times, and very innovative, simple idea that how we can understand the value of rapid initiation and titration. The best sequence is sequence 2, where there is very not only rapid sequencing up titration. These are SGLT2 inhibitors, 2 is MRA, and this red is ARNI, and this is beta blockade in this. So if you look at this patient population, the best outcome comes when you display these therapies in rapid sequencing, and then you have additional 47% gain in heart failure hospitalization and CV death, and again 13% incremental benefit in this rapid sequencing in all-cause death, which challenges us, encourages us, empowers us that all the 4 pillars are to come on board, but they have to come pretty quickly, because that is how we gain additionally. And what is always very impressive, and always I had this gut feeling that SGLT2 inhibitors although they are last in the queue, but as far as the application is concerned, they are numero uno. I always believed that SGLT2 inhibitors is the first drug in every heart failure phenotype, whatever it is, because they are the simplest to use, one-point titration, and probably you need least of care and helps you in stabilizing your patient. So SGLT2 inhibitor is numero uno. Although they are last to come, but as far as the application is concerned, they are first to be used, and the simplest drug to be used. I'm just ending up by showing this slide by one of the Nobel laureates, Rita Levy, which shows and talked about we not only have to decrease the death, we have to improve the quality of life. So ladies and gentlemen, this is a unique opportunity where we are not only prolonging the life of our patients by these therapies, especially SGLT2 inhibitors, but we are improving the quality of life, because the quality of life is the most important parameter for the patient. They don't know the quantity of life. Quantity of life is more for a family and the doctor. What matters to patient is quality of life. So this is a unique opportunity. Even in HFpEF patients, we are improving the quality of life at least. So this is a wonderful idea that quality of life is very important denominator in our patient. This is how you can complicate the usage of SGLT2 inhibitors. So I always say they are low-hanging fruit. You need not to do a great effort to put across your patients. Don't make it complicated. They are simple drugs, requires probably, if you permit me to say so, investigators like Dr. Pradeep has given us so much of insight over a period of time, because these drugs can be used with least of the wisdom, if you allow me to say, because of the safety, applicability, outcome, quality of life, quantity of life had been convincingly shown by these drugs, which took almost 20 years for lipid-lowering therapy. What these investigators have done in the last 5 years is an enormous wealth of data, quality data, applicability of this data. So I feel that let us not make complicated the usage of SGLT2 inhibitor. They are one of the simplest drugs to be used. Just I'll end up that we have to develop this wisdom, how we can use a larger cross-section of our patient across whole ejection fraction. Thank you very much.
Thank you, Dr. Raju Agrawala, for taking us through the usage of SGLT2 inhibitor across the spectrum. Now, sir, we will start the panel discussion, and then let me share the slide. So, sir, these are the few questions which we got from audience. We did survey across India, and these are the which we got doctors, and most of the questions were already addressed. But then now you can moderate the session and then start taking this, start discussion questions.
Yeah.
Over you, Dr. Raju.
Dr. Pradeep, are you on board?
Yes, I'm here. I'm ready.
Yeah. So the first question is very interesting and very simple. That who are the patients who cannot be given SGLT2 inhibitors, especially dapagliflozin? That is a very simple question.
Yeah. So now, interestingly enough, dapagliflozin, at least where I live in the UK, has a license for type 1 diabetes, but wasn't used in type 1 diabetes patients in these trials. So I don't think we know very much about those patients. I think the other group that we know very little about is the patients with very low renal function, so below 20 mils per minute. So very low eGFR. They're the patients that I don't think we really should use them. Obviously, if they've had a history of lots of ketoacidosis before, then again, those are patients that you may wish to be very careful about using these drugs. And then again, our endocrinology colleagues who are with us tonight can talk about that, I'm sure. And of course, the patients I think I had mentioned have recurrent mycotic infections on an SGLT2 inhibitor. You can try them, but again, you might be difficult. That's not really I suppose a contraindication, more of a caution, but those are the main ones. But maybe our colleagues have some other ideas.
Yeah, Dr. Kalpana, if you are on board, please guide us. What is your take in terms of who are the patients who cannot be given SGLT2 inhibitors?
Yeah, as rightly said, definitely the genital infections, especially the urosepsis and urinary tract infection, mycotic infection. So they are the first to be ruled out before starting such treatment, number one. And number two, we need to check with the euglycemic ketoacidosis, because some patient, they can land in euglycemic ketoacidosis, especially those patients, suppose one or two trials has been shown that type 1 diabetes also can be tried. So definitely we should never give these drugs with type 1 diabetes, and those patients with type 2 diabetes mellitus with a low C-peptide value, or those who are diagnosed as a LADA, latent autoimmune diabetes in adults, or patient who had a past history of pancreatitis, all those patients should never be given. And other group of patients, those who are having a low food intake or severe dehydration, hypotension, and who are having high insulin requirement due to acute medical illness or surgical illness, or those who have taken alcohol, in those patients, we should restrain giving such kind of drugs. And treatment especially should be stopped for those who are hospitalized for surgery and acute medical illness, and those patients having a ketone bodies positive. So these are the situations where we should restrain in giving such kind of drugs.
Dr. Rajan, you can take further on how you place it.
I think I'll completely agree with Dr. Kalpana, ma'am. Basically, the risk of euglycemic decay is, if you go by pathophysiology, it is because of the change in ratio of insulin and glucagon. So basically, for this SGLT2 inhibitor, there is increase in glucagon, and that makes us more prone to developing decay. But what ma'am said, in most common indication where we use in practically in SGLT2 inhibitor, that we should keep in mind, like sometimes we use as a third or fourth anti-OADs before starting insulin. So that is the patient is already having long-standing type 2 diabetes, patient is already insulin deficient. In this type of group of patients, the risk of euglycemic decay is much higher. So it is better to start with insulin so that the patient get benefit of the both drugs. And regarding pancreatic name, the chance is a little bit less because the glucagon is also less in pancreatic, but still in the insulin deficient stage, we should be cautious in starting SGLT2 inhibitor. I think rest of the thing is already covered by Dr. Pradeep and Dr. Kalpana. Thank you.
Dr. Pradeep, I want to bring you in because the kind of euglycemic ketoacidosis, which is very, very commonly talked by our endocrinologist colleagues, I somehow feel it is overrated complication. I am yet to see in last maybe 3 to 4 years of my practice in the patient profile I do it, whether they are, unless they are in acute distress. But my OPD based patient, I am yet to see, or let me say, I am yet to see admission of euglycemic ketoacidosis in my hospital. So I'll say, this is what I feel, that these are low-hanging fruits, and these are not that common the way we feel. I'm yet to see this ketoacidosis business, and the infections are there. Some patients are prone for one episode, and still minority are recurrent episodes. So I'll say, if you permit me, I am not, let me say, an academician. I am a clinician academician. If I talk of rough figures, my patient to the tune of 97 and 98% are noiseless in terms of complication, and their tolerance is exceptionally good. I want to have your inputs.
Yeah, I think you're right. So let's go over the ketoacidosis data and what you do practically about it. So the first thing is making sure you don't pick patients who are extremely high risk of ketoacidosis. Now, Dr. Kalpana Das mentioned a few of those patients who are likely to have type 1 diabetes or misdiagnosed type 1 diabetes. So these patients on very high doses of insulin, thin patients with type 2 diabetes and high doses of insulin, people who were more likely to be misdiagnosed type 1 diabetes, all of those patients. So if you get rid of those patients, you get rid of the biggest problem, I think, in terms of risk of euglycemic ketoacidosis. And then the other thing is that we need to remember it can be managed, but you need to educate the juniors and other doctors who are seeing patients at the front door of the hospital to check for ketoacidosis in the patients with normal glycemic levels. And I think that awareness is better now than it's ever been. We shouldn't say that it's not a problem. It's definitely an issue with the SGLT2 inhibitors, but as you quite correctly say, Dr. Agrawal, it's not a big issue. If you look at the incidence of diabetic euglycemic ketoacidosis, number one, it only happens in patients with type 2 diabetes. And number two, the incidence is actually lower than the incidence of angioedema with an ACE inhibitor. Now, I don't worry at night about angioedema in ACE inhibitors. I know it is a rare complication, side effect of ACE inhibitors, and I recognize that if it happens, I can deal with it, withdraw the drug, steroids if needed to help the patient get over that angioedema. I tell my patients to look out for it, but it doesn't happen that often. And maybe I've seen 1 or 2 cases. I think the same is probably true of SGLT2 inhibitors. We know from the trials that the incidence of euglycemic ketoacidosis is actually lower than the incidence of angioedema with ACE inhibitors and with RNAs. So if you don't worry about angioedema with ACE inhibitors and RNAs, I don't think you should worry about euglycemic ketoacidosis with SGLT2 inhibitors, but you must remember to make sure that you look for those high-risk patients and think carefully about using it in those patients. And if you do, educate the patient. Tell the patient if you're feeling sick, diarrhea, vomiting, stop taking your SGLT2 inhibitors until you feel better and you're eating and drinking again. And with that, I think you can really deal with most of the issues of ketoacidosis. But I'd quite like to hear what our endocrinology colleagues tell their patients in terms of stopping the drugs and when to stop them. Obviously, if you're going in for surgery, we've had a question about surgery as well. Make sure you tell your providers, tell them to stop the SGLT2 inhibitors before they start fasting for their surgery. But maybe the others have something more to add.
So can you define, you have already taken this question of surgery, can you define the timelines 2 days before or 2 days after, 1 day before or 2 days
we
after?
usually say one day before they go in and start fasting. Usually about 24 hours before they start their fasting. Yeah. What does everyone else do?
The timelines are simple. A day before you can stop, and maybe a day or two later you can start. And once again, I re-emphasize, it's probably one of the simplest drug to be used. And there is a question to our endocrinologist colleague. They can answer implication of SGLT2 inhibitors plus sitagliptin in chronic kidney disease. I can't involve myself because this is purely a metabolic question. So what is your take? CKD, sitagliptin, and SGLT2 inhibitors. Dr. Rajan.
Thank you. Regarding I think the delegate is asking about the fixed dose combination like SGLT2 plus sita and CKD. The SGLT2 inhibitor as a class effect, they have a beneficial effect in chronic kidney disease across a much lower GFR than the GFR we use for glycemic control. And that is the way that if you consider the SGLT2 inhibitor, it is beneficial for renal. Regarding sitagliptin, rather among all the DP4 inhibitor, apart from a linagliptin showing some effect in prevention of microalbumin progression in Carmelina trial. Other SGLT2 inhibitors are almost neutral in the point of CKD purpose of view. Sitagliptin usually we use in reduced dose, and we use in stage 4 onwards, and stage 3 in reduce around 50 milligram per day. So, and we have some additional benefit if you combine this SGLT2 and the PTP4 inhibitor, that they say there is a lower risk of euglycemic decay and some lower risk of genital infection. That is a synergistic effect.
Okay, there is a very interesting question, and I don't know the answer. I have never heard this question, and probably it should trouble all the people on the panel. What is the role of dapagliflozin in PCOD?
Yeah, actually, it is not approved, but if any PCOS patient, they are having diabetes, hyperlipidemia, hypertension, all those things, if that is having all comorbidities associated with PCOS, in that case, we can use. Whereas for only PCOS without any associated comorbidities, it is not been approved.
So, Dr. Pradeep, what is your take? I never heard this stretch of imagination that dapagliflozin on PCOD. What is your take?
Well, I mean, I think that's one for the endocrinologist. It's a bit outside of my expertise. I'm presuming you mean polycystic ovarian syndrome and polycystic ovarian disease. So I'll leave that one to the endocrinologist.
So we never know, sir, because when DAPA or SGLT2 inhibitor, usually like when it first came, it was for the diabetes only. Then gradually it is spreading. So maybe it improves the metabolic milieu. If you go by the how it is working cardiovascular, there are improvement in the uric, improvement in the vascular, there are improvement in the fat milieu, in the fat mass. So maybe I think the future questions or future studies might be there.
I think we just need to be careful that, you know, there's a few disease areas that SGLT2 inhibitors have a very clear indication. Number one is type 2 diabetes. Number two is heart failure with reduced ejection fraction and possibly HFpEF very soon. And number three is chronic kidney disease. Those are the three clear areas where you can use.
This can be future research question.
Yes, absolutely.
This can be the
Dr. Pradeep, when you say chronic kidney disease, like heart failure, it is independent of diabetes. Is that right?
Yeah, absolutely. So the DAPA CKD trial randomized patients with and without diabetes. We had patients in DAPA HF who had CKD. We had patients in DAPA CKD who had heart failure. But essentially, those are the three disease areas. And if you have more than one, so you have diabetes and CKD, or you have diabetes and heart failure, well, you've got two indications and you've got no excuse for not giving your patient dapagliflozin, I think.
So let me put you across one case scenario where there is a hypertensive patient who has got a creatinine on 1.8 and a GFR of 55 kind of thing. So is this a good candidate for SGLT2 on top of your conventional antihypertensive therapy? Because this is one of the biggest area which I find my clinician colleagues are having inertia. They are not using in this patient population. So what is your guidance and advice to us?
Well, if the patient has diabetes, then yes, you should use it in that patient.
Oh, that becomes simple. Non-diabetic hypertension.
Oh, non-diabetic. Well, then there's no indication for the drug in that population, I think. So if that patient has hypertension and a bit of renal impairment, it's a bit difficult. They probably would qualify under DAPA CKD, I think.
Yes.
You would want to do very clear checking albuminuria in their urine, look at the renal function in more detail. So on that basis, they probably qualify. If the EGFR is under 60, I would be looking very carefully to see if I can find a reason to give them on the basis of their renal function. Those patients definitely would benefit from DAPA CKD if you say that the renal dysfunction is secondary to hypertension.
With this understanding, I can advise my colleagues who are internists or clinicians or practicing that every patient of hypertension should have urinary albumin creatinine ratio, because the moment you display higher albumin creatinine ratio, SGLT2 can be a very big disease modifier in this patient population. And it is very underutilized facility in my country, at least in my geography. So, ladies and gentlemen, if you have hypertension, never miss, before ordering an echocardiogram, please order urinary albumin creatinine ratio.
Yeah.
So
unfortunately, it's the same as ours. It's, you know, after diabetes, it's one of the biggest causes of end-stage renal disease. So
yes,
you know, that's a disaster for a patient ending on dialysis or needing transplant. So we must try and prevent that whenever we can.
So probably I'll take the last question of the day, and that talks about what additional benefit SGLT2 offers when added to current heart failure regimen of ARNI, MRAs, and CCB. Before I bring in all the people, avoid CCB in heart failures. Avoid CCB in heart failure. Don't try to put in. Don't try.
I wonder if they meant beta blocker by accident.
Yes,
CCB, because yes, definitely all patients should be on an ARNI, an MRA, and a beta blocker if you can. And we know that the benefit of dapagliflozin is on top of these drugs.
Yes.
It doesn't matter if you're taking one of these drugs, two of these drugs, all three of these drugs, whatever combination your patient is taking, if you add dapagliflozin, they will do better. So that's my take-home message. When a patient with heart failure is not on an SGLT2 inhibitor, get them on an SGLT2 inhibitor. Even if you are not able to get them up to high-dose beta blocker or high-dose ARNI, add the SGLT2 inhibitor. They will get benefit. Add dapagliflozin.
So what I often feel that many of us, the way the drugs were discovered in terms of anthropology, beta blockers, ACE inhibitors, ARNI, SGLT2, probably they are the last in the anthropology, but practicality, they are the first to be used. So there is no sequencing in terms of anthropology. Every phenotype dictates you to use SGLT2 inhibitors as numero uno. So I think we have had good 1 hour chat and good learning from you. I'll ask my co-moderator, Dr. Rajan, to put final words of wisdom to clinicians, and then I'll request Dr. Kalpana to put final words of wisdom to all of us. Dr. Rajan.
Thank you, sir. From endocrinologist point of view, I think I will agree with to some extent to Dr. Rajiv said. Definitely the plethora of benefit we have from this molecule, and in most of the geriatric patients, I think there will be all three indications: a little bit of heart failure with the reduced ejection fraction, with a CKD, with a diabetic. When the patient, we deal maximum of the patient, so we have a very strong, I think, 3 approved indication to use a single molecule which can give you benefit for all the 3 major organs. With respect of this such benefit, whatever contraindication or whatever complication we have, that is in the minuscule. Definitely in our day-to-day practice, we see genital and urinary tract infection much more common than euglycemic decay. But definitely we need to be cautious in which of the patient we should not use it. But that should not, we should not be afraid of this complication, and we should not miss the patient where these are indicated.
Dr. Kalpana, are you on board?
Yeah, please tell me what's the question, sir?
No, the final words of wisdom. Final words of wisdom from a senior endocrinologist to cardiologist. Let me say, reframe the question.
Yeah, so this is a drug. I know this is a wonderful drug, but when the diabetic patient they come, if they are not controlled by... Hello, can you hear me?
Yeah, you're audible.
Yes, we can hear you.
Yeah. So like many
Yes,
drugs
we can.
that we use, while treating type 2 diabetes mellitus, if the blood sugar is not controlled by various drugs, we can use this drug as an add-on therapy, number one. Number two, of course, those patients having the comorbidities like atherosclerotic CVT and the DKD, and some articles, they also say that we can use this drug in NFLD and obstructive sleep apnea syndrome. In those cases also, we can start as the first-line treatment. And of course, for every diabetic patient when uncontrolled, we can start as the first line or second line treatment for this. Of course, we should know where this drug should not be given and when it should be withdrawn. And whenever there are urinary tract infection, genital infection, that should be treated immediately and drug should be withdrawn immediately. And of course, diabetic ketoacidosis, that should be looked for whenever there are severe infection in the form of urosepsis, pyelonephritis, or any kind of infection. In those situations, in my clinical practice, I have seen about at least 5 to 6 patients of ketoacidosis. Of course, they are not euglycemic ketoacidosis. They are pure diabetic ketoacidosis. That is because of the presence of urosepsis. So these need to be taken care while treating the patient with such kind of drugs.
Thank you, ma'am. Thank you. Dr. Abhijit, can we close it down?
Yes, sir. Thank you, Dr. Pradeep Jun, for excellent deliberation on SGLT2 inhibitor, as well as Dr. Rajiv Agrawal for wonderful moderation of today's session. And definitely thanks to Dr. Rajan and Dr. Kalpana Madam for discussing on various questions which we got from audience. So also I would like to thanks our sales colleague as well as the marketing team for arranging such a wonderful session on SGLT2 inhibitor. So again, as well as thanks to the IT team who bring this platform, and without any challenges, we completed this session wonderfully. So that's it from my side. So thank you very much, and then good night.
Thank you, Dr. Pradeep, for spending time.
Thank you.
Thank you, everybody. Thank you very much.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you all.
Thank you, Swapnil. Thank you very much. Bye.
Thank you, sir. Thank you. We'll be looking for one more session after publishing the DELIO trial results.
Absolutely. Whatever you need, just email me and we'll see if we can work out some time, okay?
Yes. And sir, I also tried to connect with Professor S.G. Solomon, but he has not replied. So it will be better again to post them for the program.
I can't hear Swapnil. I can't hear you very well. You're very.
Yeah, I tried to connect with Professor Solomon also.
Okay.
But I didn't get any reply from his side. So I was telling, after watching the results of DELIO trial, we'll have one more program with both of you.
Okay. Yeah, absolutely. I can definitely do that with Deliver. It's not a problem. Or